Should we start? So, we are covering two topics today. One is acute otitis media, and other is secretory otitis media. So, let's begin with acute otitis media. So, by definition, it is the inflammation of mucoperiosteal layer of the middle ear cleft. So, if we say that we have mastoid ear cells, mastoid antrum, aditus ad antrum, the recess, and the pharyngotympanic tube, they together constitute the cleft, middle ear cleft, and the inflammation of the periosteal layer of this cleft is known as acute otitis media. Typically, it occurs in less than 6 weeks in infants. 60 to 70% of children have more than one episode before first birthday. I'll only speak when you all settle down. Early onset, less than 6 months, is associated with recurrent AOM and chronic OME. OME is otitis media with effusion. So, last line means that if it occurs early in the life of the children, there will be recurrent episodes of acute otitis media and chronic otitis or otitis media with effusion. So, what are the routes of infection? 3 routes. Number 1, via eustachian tube, most common route. Retrograde mode में infection spread होता है via the lumen as well as the peritubal lymphatics. Number 2 is via external ear traumatic perforation. Number 3 is bloodborne, which is very uncommon. Common organisms we'll read ahead. What are the predisposing factors for that? Recurrent cold, common cold, a viral etiology. Upper respiratory tract infections, exanthematous fevers like measles, diphtheria, whooping cough, infection of tonsils and adenoids, chronic rhinitis, chronic sinusitis, nasal allergies, tumors of nasopharynx and cleft palate. What function eustachian tube has to play in any middle ear pathology is, I think, it is the core element. If the eustachian tube functioning is not proper, one will definitely have a middle ear disease. So, there are certain differences in eustachian tubes of adults and children's. In children's, eustachian tube is at an angle of 10 degree, means it is somewhat straight. As in anatomy, you might have read that it has 2 parts, cartilaginous and bony. ठीक है? तो उसका junction होता है isthmus. तो when the temporal bone develops, the bony part develops, along it the cartilaginous part develops as you grow older. Then angle comes as a part. So in children, it's an angle of 10 degree, while in adults, it's an angle of 45 degree with the horizontal. So by 45 degree, 10 degree we mean that, see, this is the plane, and if it is having an angle of 10 degree, so it is somewhat straight in children's. And if it is having an angle of 45 degree, ठीक है, तो उसमें इन्फेक्शन का उस तरीके से जाना इज नॉट पॉसिबल, प्लीज. सो एंगल इन चिल्ड्रन इज क्वाइट लेस, which predisposes them for middle ear infection. And the isthmus is a narrowing in the eustachian tube at the junction of cartilaginous and bony part. It is only present in adults. Okay, so it also acts as a barrier, which is not present in children's. What are the organisms associated with it? Please remember it. There are quite a lot of organisms in ENT which are responsible for this and that. Make a sequence in a single page that these are top 3 for acute, these are top 3 for chronic, these are top 3 for XYZ, etc. The most common is pneumococci, around 30%. Second is H. influenzae, that is 20%, and third is Moraxella, 12%. Other are Streptococcus pyogenes, Staph aureus, Pseudomonas. Fungal is also there, but very less, I think less than 1%. Aspergillus and Candida, Aspergillus being more common. Bacterial otitis media from superinfection of viral also is a possibility. What happens? क्या होता है? So there are 4 stages. In the first stage, there is stage of tubal occlusion. What do you mean by tubal occlusion? The eustachian tube dysfunctioning happens and tube occludes. It gets closed. So there is hyperemia. I'll show you some pictures. You'll get to know better. The second stage is stage of pre-suppuration, that is known as exudative stage. Number 3 is stage of suppuration, and number 4 has 2 parts, whether the disease will resolute or the complication will occur. So what happens in stage of tubal occlusion? Stage 1. There is hyperemia and swelling of the mucosa of eustachian tube. The eustachian tube gets occluded. The intratympanic pressure, see, we all know that eustachian tube acts as a pressure maintaining tube. It acts as a balancing tube. So intratympanic pressure decreases because when it closes, the negative pressure increases in the middle ear. So the air decreases in middle ear and fluid increases because we all know that there are mucus glands in middle ear. So the tympanic membrane retracts. What are the symptoms? There is deafness, there is earache, because tympanic membrane's movement are not good enough. What are the signs? There is retraction of tympanic membrane, loss of cone of light. The tuning fork test shows the conductive deafness. So if we do otoscopy, you will see that the cone of light almost is absent. This thing is known as lateral surface of Malleus. This becomes prominent as the handle of Malleus goes medially due to negative pressure, it comes out just like this. क्योंकि अगर ये पोजीशन है, अगर ये अंदर गया तो ये बाहर आ जाएगा. The tympanic membrane is retracted overall. The handle of Malleus is foreshortened. There is no actual shortening of handle of Malleus. The length remains the same. But what happens is, due to negative middle ear pressure, it is being pulled inwards. So it is apparently shortened. The guy in red check shirt, please come on the first bench. Oh, blue. आइए, आ जाओ, आओ, इधर आ जाओ. Stage of pre-suppuration, stage 2. So there is bacterial invasion of the tympanic cavity leading to hyperemia, leading to inflammatory exudate formation and congested tympanic membrane. Symptoms are the earache is very pronounced, throbbing in nature. There is deafness, tinnitus, high degree of fever and restlessness. Child becomes very much irritable, cries, does not take feed. Signs: the congested pars tensa, the cartwheeling of tympanic membrane. The tuning fork test shows conductive loss. So this is a photo of stage 2. Cartwheeling, by cartwheeling we mean that you can see the minute vessels over the tympanic membrane, ना दिख रहा है radially. So this is known as cartwheel appearance. There is no cone of light. Stage 3 is stage of separation. In middle ear, secretions tend to stasis हो जाता है, तो infection हो गया bacterial, so it becomes a harboring agent for bacteria and pus is formed. Tympanic membrane is compressed. जो tympanic membrane अभी तक retracted थी वो अब उसके पीछे जब पस कलेक्ट हो जाएगा तो वो बाहर की तरफ बल्ज करने लगेगी, इस्कीमिया होएगा. The TM becomes more tense and bulges, and there can occur the necrosis. What are the symptoms? Excruciating pain, deafness, fever, high grade fever 102 to 103 Fahrenheit, vomiting, convulsions. What are the signs? Red and bulging TM, yellow spot, tenderness all over the antrum. X-ray mastoid show clouding of hair cells. So this is the stage 3, bulge out tympanic membrane, loss of anatomical landmarks. And there is clouding of mastoid hair cells. You will read about it in your radiology class. The arrow is showing the white out appearance of the mastoid hair cells, which are otherwise seen black on an X-ray. Stage of resolution. There can occur resolution, there can occur complications. So resolution में what happens is tympanic membrane ruptures due to too much pressure. The pus is released, symptoms subside, resolution starts. Mild infection is present, early antibiotics and resolution with no rupture of TM if early antibiotics are given. As far as symptoms are concerned, there is still the earache which was so much excruciating, it is relieved. Fever comes down. Signs are EAC can contain blood tinged discharge or a mucopurulent discharge, small perforation of the tympanic membrane. Complication can also occur. Highly virulent organism if it is associated with the infection like measles, or the low immunity state, it spreads beyond middle ear, which can result in acute mastoiditis, periosteal abscess, paralysis, labyrinthitis, petrositis, meningitis, brain abscess. You guys had your class on SOM or not? No. So you get to know about the complications later on. What can we do? Systemic antibiotics. Frontline. Nasal decongestant can be systemic or topical. Systemics are generally avoided in children, so we start with topical. H1 antihistaminics or any antihistaminic which has a safer profile looking at the patient. Analgesics and antipyretics. Oral toileting for ear discharge. Hot fomentation for severe earache. And a review is done after 48 hours. What will happen after 48 hours? If the earache and fever persist even after your medical management, you can change or move to higher antibiotic. If the tympanic membrane is still bulging, perform myringotomy. Myringotomy is a surgery to make an incision in tympanic membrane. It is not myringoplasty. Myringoplasty is in which you put a fascia graft in already ruptured tympanic membrane. In myringotomy, the tympanic membrane is still intact. You make a iatrogenic perforation in it. Ear discharge is being taken out after making a myringotomy incision. Discharge culture sensitivity के लिए भेजिए. If the earache and fever subsides, treatment is continued for 2 weeks, around 2 weeks, and it is reviewed after 3 months. If there is no effusion behind the intact drum, then no further treatment is required. And the effusion, if it is there, then it is the otitis media with effusion is treated. We'll look ahead. Presence of abscess or coalescent mastocytitis is an indication of cortical mastoidectomy. It is a surgery in which the cortex of the temporal bone is removed or drilled out. So we have to give a passage to hold the mastoid air cell system in order to get aerated and function properly. This is done when there is an abscess or coalescent mastocytitis. What are the indications of meningotomy? If the symptoms are not relieved by antibiotics, the tympanic membrane bulges too much significantly, the perforation, if the perforation is too small, we can widen it. If there is incomplete resolution of the disease, or there is effusion which is persistent beyond 12 weeks, 3 months. So, as a brief about it, we'll read it in SOM. So, it's a surgical procedure in which a tiny incision is created in the drum to relieve the pressure caused by fluid or to drain the pus from the middle ear. So, you can see in diagram B, he has taken an instrument and has touched it and poked it in the tympanic membrane, and he has made a incision, made a hole, and through which a suction, क्या हुआ? Through which a suction has been passed, and the fluid is being sucked out from middle ear. We can also put a plastic tube which is known as grome. I'll tell you later in OME. So we have to treat the underlying cause also. You cannot leave it. If the child is suffering from rhinitis or sinusitis, whenever there is a term called chronic comes, always have a thing in mind that it is more than of 12 weeks duration. So if a child is suffering from chronic rhinitis or sinusitis, treat it either medically or surgically. You have to deal with it. If chronic tonsillitis, I have shown the grade of the tonsils 0, 1, 2, 3 and 4. They have to be dealt accordingly, I mean surgically most of the times. Or chronic adenoiditis. You can see adenoids are basically nasopharyngeal tonsils which can obstruct the nasopharyngeal airway. Adenoids पे क्लास हो गई? नहीं. Second part of this lecture is otitis media with effusion. We are done with acute otitis media. You have seen what it is. They are somewhat similar, but the terminology is it's what make them different. Acute being acute presents with say acute sign symptoms, and OME is a chronic pathology. The synonyms are serous otitis media. These are being readily asked in your exams. What are the other names of this and that and yeah, no. Serous otitis media, secretory otitis media, glue ear, middle ear effusion, middle ear hydrops. These are some other names of this disease. So, by definition, in acute, we saw that there is a word called acute, and in this OME, there is chronic accumulation of mucus within middle ear and sometimes the mastoid ear cell system. Acute में तो पूरे mastoid ear cell system का inflammation था. इसमें not necessarily it is there, but there is presence of mucus in the middle ear. Time that fluid has to be present for the condition to be chronically is usually taken as 12 weeks. What I just told you. If we have to say or label a disease as a chronic illness, it should be there for more than 12 weeks. It affects children because we know the eustachian tube, the culprit. Insidious in onset. Sterile effusion in middle ear, very important. It is a sterile effusion. that has a lot of importance in deciding a line of treatment. What they used to say and now what they are saying in the treatment part, what has changed is due to the core, that the effusion is generally considered to be sterile. So it is also seen behind the intact tympanic membrane but somewhat retracted, and it is also present with hearing loss conductive. So 50% of the patient before their first birthday get the first episode, and 80% of all get it before their third birthday. Scott Brown is our book. We read it in post graduation. So it is written there that the prevalence is bimodal. At around 2 to 5 years, when the child first attends playgroup, and number 2 is when goes to primary school, say around 6 or 7 to 8 years of age, 7 to 9 more precisely. And above 15 years, the prevalence is very low, less than 1%. It is seen more during winters. More than third of the consultation to pediatricians each year, which they generally send to us. Each episode of ASOM or AOM increases the odd ratio of developing OME by 12. One episode of acute otitis media increases the chance of OME by 12 folds. Chinese children have lower prevalence. I don't know for what reason. Males have greater preponderance than females. So, etiology. The core is again the eustachian tube dysfunction. There can be obstruction due to adenoid hyperplasia, adenoid being present in nasopharynx, and eustachian tube, the opening of eustachian tube. There are two openings, one in middle ear, inferior part of anterior wall, and the other is in lateral pharyngeal wall. So adenoid can occlude the opening of the eustachian tube. Tumors like nasopharyngeal carcinoma, palatal defects like cleft palate, barotrauma, hyperbaric oxygen therapy, and radiotherapy edema. Number 2 is spread of infection ड्यू टू chronic adenoiditis, chronic rhinosinusitis जो AOM में अभी अपन ने पढ़े थे, chronic tonsillitis, high prevalence in HIV patients, and increased secretion due to allergy can be due to milk, cigarette smoking, especially smoker must female, GERD, and infections due to unresolved acute otitis media and viral infections. What happens? Pathogenesis. Due to eustachian tube dysfunction, there is failure of aeration of middle ear and failure of drainage. And as and when there are increased secretion in middle ear, the size of the glands increases, so the secretions also. There is spontaneous resolution if the drainage pathway due to eustachian tube is established again, or there is perforation of tympanic membrane. If both continues, the dysfunction continues, or if the tympanic membrane does not perforate, the OME establishes. Host risk factors are age less than 2 years, male more than female, Caucasians are more affected, genetic predisposition, siblings with history of OME, Down syndrome, cleft, tumors, immunodeficiency, poor mastoid pneumatization, maxillectomy, prolonged intubation, and cystic fibrosis are host-associated risk factors. It is more commonly seen in children, but it can also be present in adults. Environmental risk factors are allergies, second-hand smoke, wood-burning stoves, not breastfeeding, more in winters, and the children's attending daycare center where more than 4 children are present, low socioeconomic group, and use of pacifiers. What are the symptoms? There is hearing loss, conductive most of the time. There is mild otalgia, not like acute otitis media, oral fullness, and tinnitus. Children who have hearing loss will have delayed speech and poor academics. What are the clinical features? On tuning fork test, we'll see there is obvious conductive hearing loss. On otoscopy, which has a sensitivity of around 90%, there are two signs of retraction. There is loss of light reflex, yellow gray to blue color of the tympanic membrane, and there is a slightly retracted tympanic membrane. And due to middle ear effusion, there are air bubbles and air fluid level. See, the picture is just like this. Multiple air bubbles behind an intact tympanic membrane. So ऊपर इस वाले डायग्राम में नीचे फ्लूइड है, ऊपर एयर बबल है, सुपीरियरली देखिए आप. So these are indicative of SOM. On pneumatic otoscopy is a procedure in which we introduce a thing called otoscope and then we put air through it and we see the movement of tympanic membrane. It is used to assess the mobility and position of tympanic membrane. Tympanic membrane position is observed by increasing pressure in external auditory meatus. This is known as Siegel's method or via Siegel's speculum, or via increasing pressure in middle ear. This is known as Valsalva maneuver. You might have read about Valsalva. Pinch your nose, purse your lips, and then blow through your cheeks. So air has no way to go except for to get entry into eustachian tube, and it will go into your middle ear. ठीक है? Thing you do while traveling in aeroplane. ठीक है? They can be mobile or partly mobile or immobile tympanic membrane. We can see on pneumatic. What can we do to evaluate? Audiometry. It is around 90% sensitive. Pure tone audiometry will show bilateral conductive hearing loss. This disease is generally bilateral with air-bone gap of 20 to 40 decibels. This is the audiometry which show a low frequency conductive hearing loss owing to the increase in mass factor in the middle ear, because there is lots of secretion present in middle ear increasing the mass effect, and there is conductive hearing loss at low frequency. Are you guys done with your audiogram classes? No. So in practical lectures, I think they are starting from 22nd. 25th 6th जब से वो लास्ट वीक है ना. हाँ ठीक है, वो आपके सारे क्लिनिक्स में ये सारा काम होएगा. ठीक है. Impedance audiometry is another type of audiometry done for intact tympanic membrane. It is also known as tympanometry. It is 96% sensitive, more than pure tone audiometry. It assesses the compliance of tympanic membrane. The tympanic membrane mobility increases or decreases. We put pressure in external auditory canal and we take the reading. So there are certain inferences which show that the disease is there. It's a graphical representation. It is a objective test, while the audiometry is a subjective test. There are 4 patterns of tympanometry: A, AS, AD, B and C. In otitis media, we see B and type C, B being more common. Williams test for eustachian tube is we put a pressure of around 20 millimeter of water in external canal, and we tell patient to swallow, and then we take 20 swallows, and then we again measure it after 10 swallows. So it's out of your syllabus, but I think I have written it, so I just described it. This is the type of tympanogram. Different types: A, AS, AD, B and C. B being the flat type, C the flattest line around the 0.3. This is the on x-axis we can see the pressure. ठीक है, pressure in middle ear, ठीक, and the y-axis is compliance. You'll get to read about it, don't worry. The newer methods of evaluation are sonotubometry. We put a probe in the medial opening of from the nasopharynx. We put a probe in the eustachian tube and measure the pressure. And acoustic reflectometry is again a method which is, I think, out of your context. अभी पढ़ाएंगे तो समझ नहीं आएगा. As far as further evaluation is concerned, radiology is to be done. We have to rule out any further pathology which is not being addressed. We do X-ray lateral view, nasopharynx, to see the adenoid hyperplasia. X-ray mastoid Schuller's view to see the clouding of mastoid hair cells. And MRI in certain cases, very rare, but being done. Absence of fluid in MRI does not imply that there is absence of otitis media, as 1/3 of the patient in MRI, they have fluid in mastoid but not in mesotympanum. You know about epitympanum, meso and hypotympanum? ये तो पता है? हाँ. For nasopharynx, we do posterior rhinoscopy. It is an OPD based procedure. We do rigid nasopharyngoscopy. We do Epstein-Barr virus titers in adults because EBV is associated with nasopharyngeal carcinoma. So if a patient is in adult age group is having a otitis media with effusion, it is highly a possibility that he might have nasopharyngeal carcinoma. So what about treatment? Medical treatment, we do decongestants. Systemic, we usually don't prefer them as first line, but if a question being asked, you can also say that they can be given systemically. इसमें कुछ ब्रांड नेम्स लिखे हुए हैं, डोंट कंसिडर देम. फिनाइल प्रोपेनोलामीन in the doses given, CPM in the doses given, pseudoephedrine is contraindicated now, and tripolidine. And local decongestants are oxymetazoline and xylometazoline. Remember these two drugs. These are very important drugs in ENT, and very routinely a question being asked in your written exam as well as the practical exam. The drug, their concentration and the side effect associated with them. Medical treatment, anti-allergic measures, antihistaminic, that is azilastine, topical nasal steroidal sprays, surface tension lowering agents like N-acetylcysteine. ये सब पढ़ के आ रहे हो ना यार? हाँ, सेकेंड ईयर में ही है ना अभी भी वो क्या फार्मेकोलॉजी. Antibiotics, there is no long-term benefit of antibiotics, but can be used for initial 2 weeks. They say 2 weeks. Nowadays they say 2 weeks. Earlier they used to say don't use them. मिडिल ईयर एरेशन में वी कैन डू, इफ द चाइल्ड इज कोऑपरेटिव इनफ, वी कैन टीच देम टू डू वॉल्सल्वा और पोलिथराइजेशन, विच इज ऑपोजिट ऑफ वॉल्सल्वा. Surgical treatment, myringotomy and myringotomy with ventilation tubes. These are known as grommets or T-tubes. So myringotomy we just read. So the ventilation tubes with myringotomy and doing adenoid surgery along with this procedure readily enhances the child's ability to hear again. So if we do myringotomy and put a ventilation tube, the child's hearing improves by 12 decibel around, the study says. We can do adenoidectomy. So the airborne gap, which was considered to be around 20 to 40 decibel, now comes close to 0 or to 20 decibel. ठीक है? Which is, as per WHO, is considered normal hearing. We can do tonsillectomy, cortical mastoidectomy in cases of failure of ventilation tube. Other research methodologies which are being tried are percutaneous mastoid vent following CM. These are all bullshit. CO2 assisted perforation and phalana dhimkana bekar. Ventilation tubes, we just read them about in AOM. Now they are also being used in SOM, so let's have a look at them. So ventilation tubes are made of multiple materials. They can be of say PVC, they can be of say PTFE, anything, है ना, metallic भी आती हैं. So a longer a tube stays in situ, longer it can be potential benefit. On the other hand, if the tube stays for long, greater are the chances of complications. We have made an incision in tympanic membrane by the name of myringotomy, and we have put a tube in it. We want that tube should stay for 6 to 12 months. Okay, the purpose is solved, ventilation happens, everything is done. So tympanic membrane is, see, any body part, it is just like any other body part, it grows. So you have made a perforation and tympanic membrane, उसको थोड़ी पता है कि भाई इसने क्यों किया है, नहीं, तो वो तो ग्रो करेगी, और ग्रो करेगी तो इसको इजेक्ट कर देगी. So we don't want that it should be ejected 6 or 12 months before. चलो ये बात मान ली. अगर इससे ज़्यादा टाइम हो गया तो 12 मंथ से ऊपर हो गया तो तब कॉम्प्लिकेशन होते हैं. There can be infections from external aortic canal. There can be granulation because you are making an incision in a healthy structure which has all the capacity to grow again. So granulation is a characteristic. Permanent perforation, thinning of tympanic membrane, which leads to possible retraction. However, in adults we put T-tube, which is justified routinely, as in them otitis media is likely to be persistent over years rather than months. So if we see a children and we have put a ventilation tube, so we expect it to get ejected around 6 to 8 months. But as far as adults are concerned, we expect that it should be ejected not before 10 months or not later than 12 months. ठीक है, बच्चों में कम टाइम के लिए रहनी चाहिए ऐसा माना जाता है, और एडल्ट्स में 12 मंथ के आसपास रहे. So what are the types? Grommet type stays up to 6 months. T-tube, because we want them in adults to stay longer, so they are used in adults for 1 to 2 years. What are the materials used? Silicon, Teflon, steel, titanium, gold. Now we can see the photographs in next slides. 4 main types are Shepherd, Armstrong, Reuter, Bobbin and Goodall's. They can be inserted in anterior inferior or posterior inferior quadrant if you being asked Where are they inserted? Your answer should be anterior inferior quadrant. ठीक है? They stay longer in anterior inferior quadrant, and there is a study which shows that there is no difference in radial versus circumferential incision of myringotomy. So there are certain types. Everyone is developed according to their need. I think there are 20 odd something. So what are the complications? What if you are putting in tube after doing myringotomy? What can happen? Intraoperatively, there is displacement into middle ear. If you are trying to put it in, you have a very small opening, और अगर आपने ज़रा सा भी उसको प्रेशर से पुश कर दिया तो वो टिम्पैनिक मेम्ब्रेन के पीछे चली जाएगी, एंड दैट्स अ कैलामिटी. It can also damage to ossicles if we put it in posterior superior or posterior inferior, which is not the right place to put. Early post-op में there is blockage of tube by blood, granulation, ear infection or ear discharge. Late is permanent perforation, tympanosclerosis, tympanic membrane atrophy and retraction. Otitis media with effusion has around listed 13 to 14 sequelae. Here are few. It can lead to adhesive otitis media, that is known as atelectatic tympanic membrane. It does not move with Valsalva. There can be atrophy of tympanic membrane, which can lead to formation of retraction of tympanic membrane towards middle ear and can lead to formation of cholesteatoma. There can be ossicular necrosis due to constant negative middle ear pressure, and there can be tympanosclerosis due to constant back pressure created by the secretions. Thank you.